Welcome back to the Deep Dive. Today, we're tackling a really high-stakes topic. It's high frequency, and it impacts pretty much every professional in a high-pressure job, but especially doctors. We're talking about the core professional duty of seeking help, for stress, exhaustion, or mental health challenges. And this isn't just a chat about well-being. Our sources today frame this as a must-know ethical and professional duty. So let's just jump straight into that pressure cooker scenario, because that's where this all happens, right? Imagine you are deep into a 12-hour shift. Maybe it's nights. Maybe you've just had a run of really difficult cases. You suddenly feel this intense panic, or just this complete exhaustion, a mental fog. And you realize, with this sort of cold certainty, that you might actually be unsafe to practice. You can make a mistake, a big one. What is the immediate, non-negotiable professional response in that exact moment?
That moment is exactly what our sources get into, the clash between your professional accountability and, well, your personal vulnerability. Our mission here is to really distill those core professional obligations. It all centers on one principle. It's professional to ask for help protect patients, then yourself. We're essentially translating comprehensive UK professional guidance, specifically from the GMC, the General Medical Council, and also the scoring logic from situational judgment tests, or SJTs, into clear, immediate steps you can actually use.
And these tests, the SJTs, they're a huge part of things like the MSRA, the Multi-Specialty Recruitment Assessment, right?
Exactly. And they heavily reward actions that show professional insight and a real commitment to safety. So we're giving you a concrete, high-yield framework for what to do.
Okay, let's unpack this, because I think for a lot of people, maybe outside these professions, the instinct in a crisis is to hide any weakness, to soldier on.
Yeah.
But you're saying that from a professional standpoint, that instinct is just wrong. Why is seeking help not just a good idea, but a core professional duty that the GMC insists on?
It's absolutely foundational. And the reason is simple. The duty of care to the patient trumps everything else. It trumps your ego. It trumps your fear of looking weak. When you look at the SJT scoring logic, the highest scoring answers are always the ones that mitigate risk immediately. The exam is testing whether you have the professional integrity to see your own limit, to escalate, and to make sure there's a safe handover of critical tasks.
So it's not about your feelings, it's about the risk.
Precisely. The guidance in the GMC's Good Medical Practice 2024 is completely unequivocal. It says you must recognize your limits, you must seek supervision, and, crucially, you must act immediately to protect patients if your health, be it physical or mental, could impact the care you're providing. Hiding it isn't resilience, it's a professional risk.
That distinction is just so important. It completely flips the narrative from, shame to accountability. So the top-scoring professional choice is to tell a senior and adjust your work. And the low-scoring, dangerous choice is to hide it and try to muscle through, which just increases the chance of a serious error.
That's it, in a nutshell. We have to define professional help-seeking not as a cry for sympathy, but as a mandatory risk management action. It means proactively getting support, clinical care, occupational health, or whatever, the second you think your mental state might affect your ability to practice safely. It has to be preemptive.
Okay, this is where it gets really practical then. If I feel unsafe right now, mid-word round, scrubbing in for a procedure, what is the absolute first step? Not the long-term plan, the immediate life-saving action.
Right. You have to make the clinical area safe immediately. And we have two sort of sequential high-yield actions for this. First action, tell a senior or the nurse in charge, the NIC, promptly.
The NIC being the nurse in charge.
Yes, the person actually responsible for the flow of that ward or that department. This is the only way to formally transfer responsibility and bring in the necessary supervision. You have to tell someone who can actually intervene.
And why is it so important to tell a senior, or the NIC specifically? Why not just a trusted colleague who's at the same level?
Because your colleague, while supportive, might not have the authority to manage the workload. They can't reorganize the team. A senior or the NIC has that professional accountability. They can take your bleep. They can change the rota. It's about a structural safety net, not just an emotional one. So that leads to action 2. Hand over high-risk or critical tasks immediately.
So you physically stop.
You physically stop doing things that need high concentration. Writing drug charts, consenting patients for procedures, managing someone who's unstable. You hand them over. This prevents the immediate harm. Those 2 steps are absolutely non-negotiable.
So it's a really active transfer of risk.
Mm-hmm.
What are the signs, the red flags, that demand this kind of immediate intervention?
Basically, any symptom that suggests your cognition is impaired. So feeling actively unsafe to practice is the big one. But also acute panic, suicidal thoughts, or even just noticing you're making a pattern of small errors or near misses. And of course, working while you know you're impaired without telling anyone. In the exam and in real life, concealment is a disaster. It scores terribly because it puts patients at risk.
And in that chaotic moment, having the right words ready must make a huge difference. What's a good professional model phrase for this? Something that's clear, but not overly emotional.
Yeah, you want to be factual, brief, and very clear about the need for an adjustment. Avoid apologizing. Something like, I am experiencing an acute difficulty, and I am not safe to continue without immediate support. Can we redistribute my bleep, and I need to review my urgent tasks with you in the next 30 minutes?
And that's great. It shows you get it, you're taking responsibility, but you're also demanding a professional intervention. Okay, so immediate safety is now secured. Now what? What about the medium to long term? What confidential resources should be accessed, especially to avoid that fear of career stigma?
This is a huge concern for doctors, that fear of it going on your record. But the UK system has some excellent confidential specialized pathways. We can use what I call the 3 lines memory aid. Line 1, NHS Practitioner Health. This is the flagship service. It's free, it's highly confidential, and it's specifically for doctors and dentists in England. And crucially, it's self-referral. You don't have to go through your GP or your hospital. You contact them directly. Total privacy from your employer.
That self-referral part is massive, isn't it? It just removes that barrier of fear right at the start.
It's a game changer, absolutely. Line 2, BMA services. The British Medical Association offers free 24/7 counseling and peer support. And this is for all doctors and medical students. You don't even need to be a BMA member. It's always on, always accessible, and confidential.
Okay, so that's 2 really strong options. What's the third line?
Line 3 is using your other key avenues. So your local Occupational Health Department, or OH. They're specialists in work-related stress and can help with workplace adjustments, and of course your own GP. The key is to think about using the specialized services like Practitioner Health first, because they just get the unique pressures of the job.
So after the immediate safety action, you commit to using one of those lines. What's the model phrase for that part of the conversation?
Well, the commitment needs to be proactive. You'd tell your supervisor your intent to get support, but without going into clinical details. So something like, I've secured the ward, and I am now self-referring to Practitioner Health, and I'll be contacting the BMA line today. It shows immediate professional follow-through. That scores very highly because you're managing the risk long-term.
Right. So we're moving out of the immediate crisis and into sustainable, documented management. This step feels like it's what separates a one-off panic from a proper professional health plan.
It is. This is where we focus on plan adjustments and documentation. This means agreeing to reasonable temporary changes with your senior. Things like temporary rota changes, maybe reallocating certain tasks, or just having more frequent supervision check-ins. But they have to be agreed. You can't just decide them yourself.
And the documentation, what needs to be written down.
This is critical. You need to record the handover details, the agreed interim adjustments, who the responsible senior is, any escalation thresholds you've agreed, and, really importantly, a clear review time. This makes sure the changes are temporary and accountable.
Okay, but this brings us to what feels like the trickiest part. Confidentiality. How much do you actually share with the supervisor who's managing your rota?
This is the crux of it, and it requires what we call limited disclosure. You keep your detailed clinical, personal, mental health stuff completely confidential. That's for Practitioner Health or your GP. You only share on a need-to-know basis. Your supervisor only needs to know your current fitness to practice and what adjustments are needed to keep patients safe. So, for example, I need to be off the on-call rota for the next 72 hours. That's it. Nothing more.
That distinction really solidifies the professional nature of this. So to tie this whole framework together, you mentioned a mnemonic.
Yes, a simple mnemonic to remember the whole 5-step framework, HELP.
Yep.
H is for handover safely. That's to your senior or the NIC. E is for engaged support. Practitioner Health, BMA. OHL is for limited disclosure, only on a need-to-know basis. And P is for plan adjustments and set a review time. Okay, maybe the P stands for both. Plan and review.
HELP. That's fantastic. Can you just walk us through H and E one more time? Why is that specific sequence, handover, then engage support, so important?
Because patient safety has to come first. The H handover makes the clinical environment safe right now. The E engage support sets you up for long-term protection. If you skip H to do E, you could be on the phone to the BMA while a patient is deteriorating. The structure of HELP puts professional accountability first, then personal recovery.
Okay, so we know the plan. But now we have to talk about the traps, the sneaky wrong answers the exam uses to test your commitment to all this. Where do people typically lose marks?
The decoy detectors. The exam writers are very good at tempting you with what looks like an easier path, but one that ultimately violates that core GMC duty. Trap number 1, leave mid-shift without telling anyone.
The nuclear option.
Total professional abdication. It guarantees an unsafe handover and just abandons patients. It's the lowest possible scoring option because it creates an immediate safety emergency. Then there's trap 2. Hide symptoms and work faster to compensate.
Classic soldier-on trap we mentioned earlier.
Exactly. It fails because it dangerously increases the risk of you making an error, and it directly breaches your duty to act within your limits. The exam is testing your judgment, not your stamina.
That idea that you can fix it by just working harder is such a dangerous fallacy in this context.
It is. Okay, trap number 3. Ask a medical student or a junior nurse to hold your bleep for a few hours. This is just incompetent and unsafe delegation. A student isn't registered or trained for that responsibility, and nurses have their own critical duties. You're just passing risk down the chain.
Right. And trap 4.
Tell a close friend on the rota only and ask them to cover for you informally. Now, while emotional support from a friend is great, this fails professionally. There's no official safety action, no professional accountability. The senior team remains completely unaware of a risk on their ward.
So the golden rule for ranking these answers is clear.
Absolutely. Actions that follow that sequence: tell, handover, get help, adjust, and record will always, always score higher than any kind of secrecy, hiding, or abdication.
So what does this all mean for you listening to this? We've covered the immediate duty, the confidential support lines, that crucial distinction between limited and total disclosure, and the importance of the HELP framework.
A final check on the key takeaways for you to embed. 1. It's professional. In fact, it's mandatory to seek help early. 2. Make work safe first. Hand over your high-risk tasks and escalate to a senior. And 3. Use those confidential, specialized support pathways. Remember that Practitioner Health is self-referral. And use the HELP mnemonic to structure everything.
We really do encourage you to drill these professional frameworks, especially if you're preparing for situational judgment exams. For more resources on MSRA revision and these kinds of scenarios, you can check out the materials at passthemsra.com.
And maybe we can leave you with one final thought. Many doctors worry that asking for help will harm their training or their career. But the GMC actually encourages proactive, confidential help-seeking. Supervisors are obligated to help you with reasonable, temporary adjustments. The greatest risk to your career is not admitting you need help. It's trying to practice while impaired and making a preventable error. A structured, professional approach using that HELP framework is the true definition of integrity.
Keep those core principles in mind. You'll not only ensure patient safety, but you'll be protecting your own career and your well-being too. That wraps up this deep dive. We'll catch you next time.